Well, we're going to move along now to our final lecture or talk of the morning, and this comes from Dr. Guillermo Escobar, an associate professor of vascular surgery at Emory University. And Dr. Escobar, please begin.
Thanks. So for those of you wondering why I'm here, I'm called the filler. See, we have a little space in there. They stuffed me in. Now, I'm absolutely, this is as much as I adore this conference, this has to be my best. Almost every one of the speakers here were either my friends, my teachers, or just people that I love hanging out with at meetings. So I'm so excited to be up here. So anyway, I'm going to fill in with a quick case, and I'll start out that gunshot wounds and zone ones, and it's not just for the boards. So I was called to the OR to see a patient and found that the patient was actually prone and their spine was out in the air as they were going to plan on decompressing it because the patient had a gunshot wound to the neck. And radiology called them in the middle of the case and said, hey, by the way, there may be this irregularity around the left subclavian and the left carotid. Excuse me, the right subclavian and the right carotid. So being that I couldn't do anything because the patient was upside down with their back open, I found out that the patient suffered a drive-by shooting, had a single gunshot wound, apparently somewhere in the supraclavicular region, and there was no exit wound. They found the little bullet fragments, and it shattered T1, T2, and this is sort of the screen kind of ER thing, and you can sort of see this. Oh, the patient? Yeah, she was 12. So adding to stress and discomfort, the patient is a 12-year-old, and this is a nod to my good friend Don Coleman. We had to throw in a little pediatric case in here just to entertain everyone. So the child, when we were able to flip her over, we noticed that the entry wound was right around here, and there was no bleeding, there was no hematoma. You could sort of probe in there gently, and you could see that there was this cavity inside, leading sort of medially and posteriorly. There was absolutely no evidence of any bleeding. So it gave me a little time to go look at the CT scan to see what they were talking about. And if you look on the left, sorry for the iPhone video, but you could see that between the contrast coming in on the right side of the vein and the bullet fragments, you can't really tell much of what's going on there. I swear I really tried to window it. I didn't try to torture all of you. There was really no good data on that CAT scan. And so when I ask you what you would think, I would ask Gib Upchurch, who's in the audience, and he would tell me, well, that's about as clear as the swimming pool at the Ostomy Swim Club. A line that I would often hear when I was a fellow. So clearly the plan here is, well, now we got to go in there and look around, and I did this with Middleton when he was a fellow, and we noticed that this tract and this cavity seemed to go medially. And thank God it wasn't anywhere near the subclavian because that's where the brachial plexus is, and that's the last place I want to go in trauma. This is for Don. And but then I started getting worried about the common carotid because of the way the direction that it was going. It seemed to go towards the common carotid. And when I looked inside in this hole, and we had some retractors, and she was a rather obese girl, it sort of looked like this. So this is the carotid. It's not bleeding, it's not broken, there's nothing really wrong with it. So I asked the audience, with hopefully a little more participation, what would you do? Who would just leave it alone? Any hands? Any of our panel, leave it alone? Got a lot of trauma surgeons here. How about some more studies? If you're gonna get more studies, yeah, I got some hands on studies. Anybody want to throw out a study? What would you do? You have a hole and a patient in the OR. Intraoperative? Oh, what a great idea. For those of you that want to fix it, start thinking about how you want to approach it. So this is what I did. I forced them to go find an ultrasound that I could stick in the hole, and I could see this thing. This is me trying. And notice that on the anterior surface there's this big black space. That's because there's a cavity effect from where the gunshot wound is. So I want to highlight a little bit of the weirdness of what this is. You can see this sort of weird outline and some sort of outpouchings of low density around that flow lumen, which I sort of highlight here. And then there's this thing here, which again, this is me trying to get a probe in a weird angle in a weird hole. But there's definitely something weird going on. So I tried to get this longitudinal view, and you can sort of see this sort of thickening on the outside, which is consistent with what you see on the external view. So now we see It's an intact vessel. There's no, pseudoaneurysm or anything. And I just want to highlight sort of the relationship as far as how low this is. So that's where the left, or excuse me, that should be right subclavian, I apologize. The right subclavian is coming that way and the brachiocephalic. So it's all the way down to the base. So now, I'd like to ask, nobody said leave it alone. Who would be interested in maybe doing an angio and stenting it? Any takers there? You would do an angio? Okay. Say again? So I do want to highlight she's 12. Angio? Okay. And what would change if you found something on the angio? What are you looking for?
Any pseudo,
Okay. And if there was no pseudo?
I would leave it.
You would leave it alone. Okay, good. Can I ask anyone in the panel behind me? Oh, the whole back row can't see. Oh, damn. It sounds amazing, says Dawn. That leaves the front line. May I have any thoughts on what to do?
I agree, get an angio.
An angio?
Yeah.
Okay. So the logistics of doing an angiogram on a 12-year-old in a children's hospital are far beyond.
Difficult.
What's that?
Probably difficult.
Yeah, really hard. And the patient's like in the OR and for French and the whole thought of like doing that and packaging her up, taking her out of the OR to take the angio did mess with me. If you were to decide to excise it, anyone in the room, how would you approach it and how would you consider heparinizing given that the patient has an open spine that they just did? Any thoughts there? So I'll keep going. So I'll tell you what I did. First thing I did is I called Will Jordan in a panic and I said, oh my God, what do I do? Do I sit on this? Do I look at it? If it breaks in the middle of the night, I will never, ever live. I'll quit surgery because I killed a 12-year-old. And ultimately, he encouraged me to, if I thought it needed to be fixed, to fix it. And then we called the CT surgeons. And if any of you have ever talked to a pediatric cardiac surgeon, if there's one thing they have absolutely no interest in their entire career for the rest of their lives when they did 30 years of fellowship, is trauma. So none of them had any interest in owning the patient, so they gave it to me. So I did a mini sternotomy, clamped at the origin of the CCA, got distal control from the neck incision. I didn't connect them, I didn't do an extension, and transected it and flushed cephalide with heparin. I figured the blood would keep the right side going. And then I did an end-to-end with an 8mm PTFE. And we opened up the artery just to see, did I guess right? And thank God, there were two big holes, and you can see sort of the correlation between this one, and then the other one is the other one. So probably would have broken at some point. It looks really impressive for those of you in the back. Sorry, you can't see it. We irrigated, moved the sternocleidoid, mastoid, put a drain in. She remained extubated. ENT developed interest and dug around and found something in the trachea. She remains a T4 paraplegic from the injury to the spine, but I had a follow-up CTA and I saw her later, and over a year later, she is well and in a wheelchair and going to school. So quick review for the audience, which we range from medical students on. Zone 1 is from the clavicle to the cricoid. Zone 2 is from the cricoid to the base of the mandible. I found this drawing on the internet, and it's really funny for those of you in the back. But you can put anything on the internet, but let's try this one instead, and that just sort of gives you Zone 1, Zone 2, Zone 3. Penetrating neck injuries are 1% of all trauma, and only about 5% of all mortalities in trauma. 80% of patients that do die from penetrating injuries, it's mostly from cerebral ischemia. And 20% the remaining bleed, and the sort of classic hard signs are airway compromise, expanding hematoma, or obvious bleeding, or hematemesis. So if the patient vomits blood, then you're worried about esophageal injuries, etc. Large subcutaneous air or a big air leak on your chest tube, and a neurodeficit, which I'm not right sure. The so-called soft signs are hemoptysis, blood in the pharynx when you open the mouth and see blood in the back, dysphagia, dyspnea, dysphonia, sub-Q air. These are things that you may consider in the right patient whether or not you should take them to do an exploration. And then finally, if there is a concern for vascular injury, please don't probe the hole. That's what you don't want to do. You have a stable hematoma and somebody gets a stick and says, well, let's see what that does. So please don't poke skunks. You hold pressure if they're bleeding, and if that doesn't work, there's a cool little trauma. If you ever read a trauma book, there's all these crazy ideas that people come up with, but you can put a Foley inside of a hole. And if you remember, A lot of times there's this sort of cavity, as you saw in the ultrasound, and if you can fill that cavity with something big that's relatively low pressure, you sometimes get away with it. As far as sternotomies and thoracotomies, again, for the learners in the audience, the ascending aorta and the first two branches, so the sort of the brachiocephalic and the left carotid, you can get to from the anterior approach. I love this picture from Netter where it shows everything beautifully, but just for the audience, if you put a sternotomy, this is what you can see. So you can get to the first two branches, but the left subclavian gets a little bit hard unless they're really skinny. And finally, if it's from the left subclavian or beyond, you generally want to do a thoracotomy. And I'll end there. Zone 1 for the neck. It's not just for the boards, but the boards can keep them.